Infectious and Inflammatory Disorders of the Eye by Leonardo de Vicente, MD, and pre-med disciples. This is going to be the first of a 4-part series on ophthalmologic pathology tested by the USMLE. Before we get started, let me just tell you a little bit about myself. I did undergrad at Stony Brook University, medical school at Brown University, residency now in HCA South Florida at Kendall Regional Medical Center, and I'm an emergency medicine resident. Here are my social media plugs if you want to give me a follow, and don't forget to like and subscribe if you enjoy this video. Some disclosures: I have no financial relationship to ophthalmologic companies or optometric companies, but I do receive compensation from Amazon.com for any and all products that I recommend. But it has nothing to do with any particular company. I could recommend any product from Amazon and I would receive compensation for it. And a disclaimer. Please read this. Essentially, it says, don't blame me if something goes wrong and you use this advice. You should ask your advice from your physician. Here's the USMLE topic list. This is the order I'll be going in. The rest of the things that are crossed out in red we'll cover in another day, another lecture. So my objective today is to review the diagnosis and treatment of infectious and inflammatory disorders of the eye tested by the USMLE, and identify life or vision-threatening signs and symptoms of eye pathology requiring immediate ophthalmologic evaluation and treatment within that above topic. This lecture is best for medical students or non-ophthalmology residents or people reviewing for the USMLE. Again, I'll just say this right at the onset. Some warning signs of serious ocular disease in a red eye is reduced visual acuity, corneal opacification, corneal disruption, ciliary flush, pupil abnormalities, proptosis, or elevated intraocular pressure that is greater than 22 millimeters of mercury. Sometimes people use 20. If these things are present, they need some sort of ophthalmologic follow-up or immediate evaluation. Okay, so this is our order which we'll be going in today. So why don't we start here with Blepharitis, and then we'll mix into their preseptal cellulitis, and because it's related, orbital cellulitis. Now, I'll be reviewing some anatomy here, but only relevant to what we are reviewing. I'm not going to review all the anatomy of the eye. I just want to go through what's relevant clinically and what's relevant for the USMLE, with the assumption that you've already taken an anatomy class. So you have your upper and your lower eyelids, called tarsi plural, tarsus singular, if you want to use your medical words. And then at the interior portion of the base of the eyelid is this meibomian gland, shown in white here. And those meibomian glands are often get clogged or get slowed up in their excretion of lubricating agents in blepharitis. Again, a blepharitis is inflammation of the eyelid, and you've got anterior and you got posterior blepharitis. Anterior is inflammation at the base of the eyelashes that often presents as scaling on the eyelashes, as shown here, or crusting, scaling. It's usually due to staph infection, usually from your normal flora overgrowth. The posterior blepharitis is the inflammation of the inner portion of the eyelid, and you can see here, this eyelid up here is edematous. Again, staph is the usual cause, but there are other flora like Corynebacterium and Cutibacterium acnes that may be involved. Whether you're dealing with anterior or posterior, the treatment is the same. It's good lid hygiene, and what that means is basically washing the eyelids with baby shampoo and warm water, using warm compresses, and or removing the offending agent. If it's some sort of makeup, or if it's psoriasis or seborrheic dermatitis, treating that. So basically, if this blepharitis isn't going away, you might want to think about those other causes that aren't bacterial, like something like a contact dermatitis, eczema. Some complications are dry eye disease, hordeolum, and chalazion. You'll notice these gold staffs with the A on the end to represent Staph aureus as the typical cause, and really not just Staph aureus, but just staph in general, staph species. So let's talk complications now. And again, and clinically, no one will really get mad at you if you give someone some erythromycin ointment for this, but the real answer is no need for antibiotic, just good lid hygiene, warm compress, and remove the offending agent. Now, complications of these long term is a hordeolum or a sty, same thing, hordeolum, sty, hordeolum. It's an abscess of the eyelid that presents as a localized painful and erythematous swelling. And I have some pictures for you here. You'll notice if you were to physically examine this, it would be warm, fluctuant. Now, these spontaneously resolve, and the treatment is the same as Blepharitis. If it doesn't go away, you may need to do a needle decompression. Now, obviously, if you do that, you want to be very careful about puncturing the eye. So you'd probably cut the tip off of a needle protector and use that to prevent you from going deeper than you should. Sometimes these hordeolums may transform into a chalazion. A chalazion is typically presents as a painless, localized eyelid rubbery mass. So how you differentiate these hordeolum and chalazion is one's painful, one's painless. And the other thing is the physical exam. When you feel the chalazion, it should feel rubbery and hard, where the sty should be fluctuant and warm. So what it really is, it's really a granuloma under the skin. Now, the thing that they'll always test you on the boards is this a chalazion or is this a malignancy? You won't be able to tell, but if it's still there after 6 months, you gotta biopsy. Absolutely, you gotta biopsy it. Otherwise, that could very well be a malignancy. Now, I just want to go over some other eyelid lesions that you may confuse with a hordeolum or a sty, same thing, or a chalazion, even though they're not inflammatory. So here's one, xanthelasma. They are soft, yellow, cholesterol-filled plaques around the eyelids, usually in older adults that's the result of hypercholesterolemia or primary biliary cholangitis or both. So again, this is just lipid-filled structures here, so you're going to have to check their cholesterol, their lipid panel. Molluscum contagiosum, that's from a pox virus infection. How you know it's that is you're going to have this vesicular lesion with this umbilication in the middle or this central indentation. This one is not really readily apparent, but that's the best picture I can get. Seborrheic keratosis is these stuck-on, crusty, benign lesions. It's keratin overgrowth, and this isn't obviously an eye, but this could be on the eyelid. Actinic keratosis is a precursor to squamous cell carcinoma. My mnemonic on that is actinic keratosis is the bad actor. And again, this could present on the eye as well. Some other ones you want to look for is squamous papillomas. And those are from HPV infections. They're skin tags. They're benign. You can just clip them off or do some cryotherapy on them to remove them. It's basically, you ever see people with little balls of skin that are like sort of floating or hanging from their neck? That's what that is. You can have some pigmented skin lesions like moles, and you can have milia, so small plug sebaceous glands. Okay, after that aside, let's return to the inflammation of the periocular structures. Now, here's the thing about this. All right, you have blepharitis, inflammation of the eyelid, but then you also have conditions called preseptal and postseptal cellulitis. One of them is benign, and the other one is vision and life-threatening, and sort of looks like blepharitis, but isn't. So here we go. The reason why one is life-threatening and one is benign is this. They're the thick, pearly white connective tissue sheath called the orbital septum that compartmentalizes the eye and its surrounding structures. So here we have the eyelid here. Here's the internal structures here. Here's the globe. Here's the fat. Here's the ocular muscles. Where preseptal cellulitis as well as blepharitis occur is anterior to this orbital septum, and where postseptal cellulitis, as the name suggests, is posterior to the septum, this thick, white, pearly connective tissue sheath. So infections typically don't cross over from one side to the other. Particularly, they don't typically go in a posterior direction. So preseptal cellulitis does not typically convert to orbital cellulitis. And if you're asked this question on the board, the answer is no, it does not. Okay? Now, in children, that's different. In children, there really is no septum. In neonates, I should say, there really is no septum. But In adults, this is true. So, preseptal cellulitis, aka periorbital cellulitis, as you can see here, is inflammation of the eyelid, but also the periocular structures. But it doesn't involve that orbit or the internal ocular structures. It's usually very mild. They're caused typically by staph and strep species. So is the other one, the life-threatening one. The treatment here, you give them some oral antibiotics, they go home. You just need to make sure you have some sort of MRSA coverage, methicillin-resistant Staph aureus. So you need to give them either P-Oclinda or TMP-SMX plus ceftonir is the treatment regimen. In contrast, orbital cellulitis, aka postseptal cellulitis, is an infection involving the context of the orbit, such as the fat and the ocular muscles, but not the globe. It's vision and life-threatening. Again, the spread here is not from preseptal, but from sinusitis typically. Now, both these conditions have ocular pain, eyelid swelling, and erythema of the periorbital structures. But only orbital cellulitis has ophthalmoplegia, so palsy of the ocular muscles potentially, pain with eye movements, and proptosis. If any of these things are present when you're examining the patient, you need to treat it as orbital cellulitis. So the diagnosis is clinical. You see this, you do your extraocular muscle movements, and you do your vision check. And if any of those things are abnormal, you need to treat it as orbital cellulitis. You can do a CT scan to check for complications. The treatment is IV vancomycin plus IV ceftriaxone plus an ophthalmology consultation. So I have my vancomycin van for vancomycin, get your nice MRSA coverage, as well as our ceftriaxone Axe. Now we move on to Dacryocystitis here. Dacryocystitis is a much more rare bugger, but nonetheless important to be aware of. It's inflammation of the nasolacrimal sac. So a quick anatomy review here. You have your lacrimal gland here that's instrumenting tears into the surface of the eye. And of course you have your input, and now you have your output, which is these nasolacrimal canals leading into the nasolacrimal sac, through the nasolacrimal duct, and out to the nose. The inflammation is mainly in the nasolacrimal sac in Dacryocystitis. The etiology typically is congenital or acquired dacryostenosis, which leads to stasis of tears, secondary bacterial infection, and then inflammation of that sac there. Now, neonatal Dacryocystitis is life-threatening. Very life-threatening in neonates. You know why? Because of what we just reviewed. Their septum is not formed yet, so they can easily get orbital cellulitis, brain abscesses, or meningitis just from spread. So when you see this on a baby, you must resist the urge to probe it or push on it or palpate too roughly, because what's going to happen is you may very well spread that infection. So if you see any pus, you can take a probe of it to culture it to guide your antibiotic treatment, but don't push on this lesion on a child. The diagnosis is clinical, but an examination would show a classic painful swelling below the medial canthus, as shown here. This is the medial canthus. This is the lesion. Painful, warm, swelling. Again, it's a clinical diagnosis, but when someone sees this, they may do a DCG study, which is the cryocystography study. Basically, you put a dye in the eye with an eyedropper, and then they go for a CT scan, and that will illuminate the nasolacrimal sac and duct and show where the stenosis is. The treatment is antibiotics, warm compresses, and pain control. NSAIDs. So the treatment options are oral Clinda or oral amoxicillin clavulanate or IV vancomycin empirically. And then you can change to culture-specific antibiotics. You may need to do an incision and drainage if the lacrimal sac abscess occurs. And surgical ostomy may be required after treating the infection if obstructed. Now that IND would be done by ENT, ear, nose, and throat. Okay, the summary. Dacryocystitis, inflammation of the nasolacrimal sac. Treatment, oral Clinda or oral amoxicillin clavulanate. and then you change it based on culture, and then of course do not probe that on a neonate. So we have our keep clean sign for clindamycin treatment. Okay, let's move on to uveitis now. Let's do an anatomy. Okay, let's move on to uveitis now, which I think will require an anatomy review for most of us. Alright, so here we have the globe anatomy here. This is the globe. The sclera is the white part of the eye, the retina is the inner part. You have your optic disc here, which contains your nerves, your arteries, and your veins. Optic nerve, optic art, and then the veins and arteries. Here we have our aqueous humor. Here we have our vitreous humor. The pupil is the opening to the eye. Here is the cornea here. And then there's the conjunctival layer, which really isn't represented here on top of this. Here's the lens here, and then here's the ciliary bodies. So the uvea, the choroid body, the ciliary body, and the iris. So the iris here is the colored part of the eye. The ciliary body, and there are two, hold the lens in place. And then the choroid is the middle layer of this three-layered portion of the eye. Sclera is the outer, choroid is the middle, retina is the inner. Vitreous humor, again, just in case some of you don't know, it's really a gelatinous structure. It's not just fluid. And because this will be relevant later on, I will cover this retina fundoscopic image now. So here we're showing an image of fundoscopy where you take your fundoscope and you look into the patient's eye after dilating it, and this is what you would see. Here you have your optic disc. Inside there is an optic cup, which really isn't well defined in this image, but it could be well defined in other images. You have your retinal vein, which is a little bit darker than the retinal artery. And then you have your fovea, which is where our maximal visual acuity is, particularly in the macula, is the maximal point of visual acuity. Fovea is also helpful in visual acuity. It gets better and better as you go to the macula. And now we can move on, after discussing that the uvea consists of the choroid body, the ciliary body, and the iris, to talk about uveitis. Uveitis, inflammation of the uvea. The best way to break it up is anterior versus posterior, because regardless of which one you're using, ophthalmology needs to see the patient. Ophthalmology needs to see the patient. You can also break it up into specific areas, but that's for ophthalmologists. Anterior uveitis can involve the iris, iritis, can involve the ciliary body called cyclitis, or both, iridocyclitis. Posterior uveitis, again, choroiditis for the choroid, retinitis for the retina, or both of them, chorioretinitis. Now, the key with anterior uveitis is that it's painful. It has decreased vision or visual acuity, plus or minus photophobia, typically depending on whether or not the ciliary body is involved. Because as you can imagine, if the ciliary body is what's opening and closing the diameter of the pupil, and the light can cause those things to happen, and it's inflamed, it might hurt with photophobia. Okay, so you may even have a hypopyon in these. Again, you can probably have this in posterior too. It's just accumulation of pus in the anterior chamber. But the key thing, again, with anterior uveitis is painful, has decreased vision, possible photophobia. Posterior now is painless. So PP, posterior painless, posterior painless. But associated with floaters and scotoma and vision loss. And why do you think it's associated with floaters and scotoma? Well, it's because it's involving the retina, which is involved in signal transduction of light into a mental representation of an image within our brain. Some infectious causes of posterior uveitis is toxo, CMV, and others. So I have a picture here of chorioretinitis. You can see some edematous change within the retina. As well as some hemorrhage as well in this area. We'll go over that in a second in another lecture, really. And I have the Blepharitis sign to remind us of Cytomegalovirus. Are there others? Yes, but it seems like the boards cares about Toxoplasmosis and CMV the most. There's also systemic inflammatory disorders that can cause this, like sarcoid, rheumatoid arthritis, juvenile idiopathic arthritis, Behçet syndrome, and HLA-B27 associated conditions like IBD, like ankylosing spondylitis, etc. Ciprofloxacin can rarely cause the uveitis. The diagnosis is via slit lamp exam and ophthalmoscopy, fundoscopy. Treatment is referred to ophthalm management in the ED. So how do you find out if you might be dealing with a uveitis? You got a red eye, right? And you're like, is this conjunctivitis or is this uveitis? Well, you look for visual changes, floated or scotoma, and you ask a good review of systems and physical exam. You check extraocular movements. You check visual fields. You have them at least count fingers. If not, you pull out your Snellen chart and make sure you get an accurate visual check. You check your pupillary light reaction. You check for accommodation, and you check what symptoms they might have. Now, the key thing is with the ROS, like, you'll never pick up an IBD associated uveitis if you don't ask the patient with eye pain if they have diarrhea or constipation or bloody stool, unless they volunteer that information to you. But they may not think it's relevant, but you need to know that it might be relevant. Okay. So some pictures here. Here's toxoplasmosis, of a scar of toxoplasmosis. It is a really characteristic finding. Pathognomonic here. And then these megaloprices for CMV retinitis. This is a classic ketchup on cottage cheese appearance. It's blood on exudates within the retina, as you can see here. There's also a classic frosted branching, which is the exudates coursing along blood vessels. So you'd see like yellow surrounding this. That's frosted branch. That's classic for Cytomegalovitus Uveitis. So the treatment is you call ophthalmology and let them decide. But if maybe you're an ophthalmology resident or something, you give them a cycloplegic to stop that pain response from the iris contracting the pupils. So atropine. And then if it's non-infectious, you give them steroids. But you have to rule out other infectious causes. And then if it's infectious, you give them antibiotic or antiviral therapy, depending on what you think it is. We move on to traumatic iritis. It's the ciliary muscles and iris that are inflamed from a trauma, such as being hit in the eye. The symptoms include photophobia, decreased visual acuity, and it's painful. Now, ciliary flush may be present in traumatic iritis. It's a ring of red or violet spreading out from the cornea of the eye. The diagnosis is made via slit lamp exam, which shows the cells and flare appearances, really just little specks within the aqueous humor that have a smoky appearance. I don't have a picture for that, unfortunately. The treatment is steroids once you rule out infection, and atropine drops and analgesics like NSAIDs. Again, ciliary flush is a danger sign often seen in eyes with corneal inflammation, iridocyclitis, or acute glaucoma. Usually, ciliary flush is not present in conjunctivitis, and this is it. It's flushing of the peripupillar area. Okay, let's go on to conjunctivitis, keratoconjunctivitis. We're almost there, folks. So again, a quick anatomy review. The conjunctiva is a single cell layer thick that has two continuous parts. The tarsal conjunctiva, so on the eyelid, and then the bulbar conjunctiva on the globe, on the sclera, really. And this is a terrible picture, but here it is. Okay, you see the pink. And it secretes mucus and is a little barrier to infection. Now, when we're talking about the conjunctiva, I just can't help but sneak this one in. It's a subconjunctival hemorrhage shown here. You'll notice it doesn't cross the limbus, and it's really a hemorrhage of one of the terminal branches of the long ciliary arteries that are under the conjunctiva and just ruptured by spontaneously. And it's a benign condition. There's no treatment. You just provide reassurance. But make sure when you do examine the patient that you ask them what other bleeding they might have, like from the nose, if they notice blood in their urine or their stool or something. But generally, this is spontaneous rupture from, sneezing. It's benign, and you just provide reassurance. Okay, so conjunctivitis. It's inflammation of the conjunctiva, that single cell layer thick that is right on top of the sclera that secretes mucus. Some general signs and symptoms of conjunctivitis is conjunctival injection, that is, conjunctival dilation of blood vessels that leads to ocular hyperemia and reddening, basically ocular dilation and reddening. That's a good thing, you know. That's moving out anything that's causing the inflammation. It's moving out microscopic pathogens that may be in your eyes. That's a good thing. There's a blood vessels dilating. Okay, you may have discharge in crust form. You may have chemosis, which is swelling of the conjunctiva. I have a picture of that in the next slide. You may have burning or foreign body sensation, some photophobia, or some itching if it's the allergic type. So that's conjunctival injection. Notice that it's also not crossing the limbus. If you had some erythema coming from this area here, then you would call that ciliary flushing. But I better have ophthalmology evaluate this. Okay, here's chemosis. It's really what it is edema of the conjunctiva, and it looks kind of scary, doesn't it? It looks almost like a ruptured globe, but it ain't. It's chemosis. So for conjunctivitis, what we need to be able to do clinically is differentiate between viral, allergic, and bacterial conjunctivitis. It's actually quite simple. Viral is typically bilateral. There's redness, and there's clear watery discharge, and the treatment is that it self-resolves. The most common cause viral is adenovirus, so I have adenolions here to remind us of adenovirus. Allergic, it's bilateral. There's redness, there's clear watery discharge, but the key thing is that it's itchy. If it's itchy, you treat it as allergic. And the treatment is PO, antihistamines like cetirizine, and ketoxofen drops. It's an anti-allergy antihistamine that is dropped into the eyes. Then there's bacterial. Now bacterial, I've made only one eye here because it's unilateral. There's redness. There's also, though, thick purulent discharge, either white, yellow, green, crusting, or discharge. That is bacterial conjunctivitis, as long as there's no vision changes, right? And the treatment for it, if there's non-contact wears, you can use erythromycin drops, or you can use ofloxacin drops. But the thing is, with contact wears, you need to use ofloxacin drops because you need pseudomonal coverage. The most common cause of bacterial conjunctivitis are Staph aureus, Moraxella catarrhalis, and then Haemophilus influenzae. And in contact wearers, you're thinking Pseudomonas as well. Those are the three. And is this how we practice clinically? Yes. If someone comes into your clinic and says, I have bilateral red eye or bilateral pink eye is the term that they use colloquially, you treat them as allergic. If they come in and say have bilateral red eyes, there's no purulent discharge and it's not itchy, you treat it as viral. If you come in, there's purulent discharge, crusting, and it's unilateral, you treat it bacterial. Again, you always have to make sure there's no vision changes or anything of the warning signs of serious ocular disease. Then this keratoconjunctivitis is inflammation of the conjunctiva and the cornea. It's usually only viral, usually adenovirus. Again, if you have this patient and you see some sort of infiltrate on your pen light exam, you may want to refer to ophtho. You should refer to ophtho because it may warrant glucocorticoid therapy. All right, some other viral keratitises. Herpes simplex keratitis. It's a herpes infection of the eye, particularly of the corneum. The clinical features are similar to viral conjunctivitis, but in this case, it's usually unilateral. There's eye redness and eye pain. There's foreign body sensation, and there's photophobia. The diagnosis is done via fluorescein staining. There will be superficial corneal erosions, aka dendritic ulcers, that resemble branches of a tree, as shown to the right here. So here are the superficial corneal erosions, aka dendritic ulcers, of herpes simplex keratitis, where you take your UV blue light and you illuminate it after you put some fluorescein dye in the patient's eye and had them blink a little bit. And this is what you would see. The treatment is oral antivirals like acyclovir. And you'll notice the bulbs at the end of these for herpes simplex keratitis. You'll notice in the next slide you'll have herpes zoster keratitis, which don't have those bulbs. The clinical features here are headache, malaise, and fever as a prodrome to the visual changes, like impaired vision, foreign body sensation, photophobia, and eye pain. And there may be, in the innervation of the ophthalmic nerve V1, that is the forehead bridge and the tip of the nose. A vesicular eruption, that is your typical herpes zoster, lesions of several different ages. Anesthesia dolorosa, which is pain felt in the area, but the area is completely numb to the touch. And maybe Hutchinson's sign. Again, these are all maybes. The diagnosis is via slit lamp examination and fluorescein staining, showing pseudodendritic ulcers or lesions, and called pseudo because there's no terminal bulb on these. So you'll notice, it's not the best picture, but there are no terminal bulbs here on these dendritic ulcers, and it looks like the branching of a tree. So pseudodendritic ulcers are what they're called. No bulbs. Treatment is oral acyclovir. Okay? Alright, so Hutchinson's sign is blistering associated with herpes zoster infection at the tip of the nose, and it's often associated with and precedes ophthalmic involvement of zoster infection. And there it is, Hutchinson's sign, the blistering at the tip of the nose. Then you gotta check, you gotta think, well, now I need to stain the eye and look for pseudodendritic ulcers of herpes zoster. Then we have bacterial keratitis. It's bacterial infection of the corneum. It's usually staph or Pseudomonas. And risk factors are contact lens users. In this case, I have a picture of it. There's white opacification visible in the center of the cornea. That's a corneal ulcer or bacterial keratitis. The clinical features show progressive pain, foreign body sensation, purulent discharge, excessive staring, redness, conjunctival injection, photophobia. If it's pseudomonal, it's most commonly in a contact lens user. That's why we always ask, do you wear glasses or contacts? It's characterized by a fulminant course with severe ulceration, corneal destruction, perforation within 2 to 5 days. So the most common thing is, I fell asleep with my contacts on and now my eye hurts. The diagnosis is slit lamp examination. You may show a hypopyon, which is again a collection of pus in the anterior chamber. And you may have a corneal infiltrate or corneal ulcer. The treatment again is ofloxacin drops to cover Pseudomonas, and of course, ophthalmology. This is an ophthalmologic emergency, and ophthalmology needs to see these patients. Now, with all that said, what important vision-threatening differential must you think about in a patient that looks like bacterial keratitis but isn't? Acute angle closure glaucoma is the answer there. So basically, because the acute angle closure glaucoma may have this corneal opacification that bacterial keratitis may have, and the one that I showed you in the last image was very impressive, but sometimes it can be very subtle. Again, warning signs of serious ocular disease in a red eye. Reduced visual acuity. There should never be reduced visual acuity in simple conjunctivitis, unless there's associated corneal involvement, which again is serious ocular disease. Corneal opacification. Again, acute angle closure glaucoma, bacterial keratitis. Others. Corneal disruption, ciliary flush, pupil abnormalities, proptosis, elevated intraocular pressure. Do you remember where some of these might be? I can think of some. Corneal disruption. Okay, you've got a corneal ulceration. You've got corneal foreign body. You've got a corneal abrasion. Ciliary flush. Okay, traumatic iritis you might be dealing with. Iritis you might be dealing with. Some sort of uveitis. Any pupillar abnormality, like one pupil within clothing like the other, for example. One's not opening like the other, for example. Proptosis. Okay, traumatic injury, which we haven't talked about yet. Elevated intraocular pressure, causing proptosis. Orbital cellulitis. Elevated intraocular pressure, the one that I think about most commonly is acute angle closure glaucoma versus orbital compartment syndrome. Okay, well, you were talking about these as we move on. One more keratitis, ultraviolet keratitis, aka snow blindness. This is an interesting one. It's a radiation burn from UV light. The typical question stem is, they're the patient who was snowboarding and now is having some trouble with seeing, vision, and photophobia. But it could be from a tanning booth, and really what it is high altitudes are really close to the sun, but also have this reflective capacity due to all the snow on the ground. The presentation is 6 to 12 hours after exposure. They have eye pain, eyelid blinking, several blinking spasms, tearing, photophobia, and foreign body sensation. The diagnosis is a fluorescein stain of the eye will show superficial punctate epithelial surface irregularities, which usually cover the entire surface of the cornea. But there may be a well-demarcated line if part of the eye was closed as it was exposed to the light. The treatment is topical NSAIDs plus oral pain medication, plus or minus topical antibiotics to prevent bacterial superinfection. Don't give them tetracaine drops to go home with. And this typically will resolve in 72 hours without complication. Finally, optic neuritis is our last thing to talk about. Okay, optic neuritis. It's an inflammatory demyelinating condition that causes acute, usually monocular vision loss. Most cases are due to multiple sclerosis. As you guys all know, multiple sclerosis is lesions of the central and peripheral nervous system that is disseminated in time and space. So you got patients that are coming in with maybe, urinary retention, but they also say, oh, the symptoms get worse when I take a hot shower. Oh, they have this weird thing where they can't move part of their arm, but they also can't move another leg, a part of their leg, and it's all like doesn't really fit in one single lesion to the brain. That's MS. The toxins are that can cause optic neuritis are methanol ingestions, and the common thing is someone making moonshine, and the treatment would be fomepizole. And then the toxin that may cause it is ethambutol. Those are the two that they like on the boards. Ethambutol is used in the ripe treatment of tuberculosis. Other causes of optic neuritis is tuberculosis itself, syphilis, Lyme disease, sarcoidosis, or viral infection. But again, most cases, multiple sclerosis. On exam, you may have an afferent pupillary defect that is a Marcus gun pupil. And you are probably familiar for this by now. It's basically you're doing your swinging flashlight test. And the affected eye is where the light is being shown. And it is that eye because it's an afferent pupillary defect. So the sensory afferents of the affected eye are not working appropriately to tell the contralateral eye to constrict. And so when you do your swinging flashlight test, you're showing a light on the affected eye will constrict, but the sensory afferents aren't working, so it cannot tell the contralateral eye to constrict, and so you have dilation of the pupil on the opposite side. The diagnosis is clinical. How you make the diagnosis is worsening vision, afferent pupillary defect plus grossly normal fundoscopic exam. But there may be mild papilledema. Of course, you can do CT scans to check for lesions and such. The treatment is a high-dose IV steroids. Usually, they'll have normal vision within 1 year. That's all I have for this lecture. If you enjoyed it, don't forget to hit like and subscribe, and follow me on all my social medias. This is Lariano Andrade Vicente, MD, from Pre-Med Disciples. Hope you have a great day, and hope you're seeing clearly.